Have we been making oxygen therapy more complicated than it needs to be? Over the past decade, we've debated high-flow versus non-invasive ventilation, conservative versus liberal oxygen therapy, and increasingly complex respiratory support strategies. But this week, two major publications challenge us to rethink when those choices truly matter and when they don't. In today's episode, we'll review the brand new American Thoracic Society Guideline on non-invasive respiratory support, examine a large randomized trial asking whether conservative oxygen improves neurologic outcomes after cardiac arrest, and finish with an ICU physiology review that explains why hypercalcemia can become a life-threatening critical care emergency. These are studies that won't just update your knowledge. They're likely to influence decisions you make on your next ICU shift. Welcome to This Week in Pulmonary and Critical Care Medicine, your weekly evidence-based briefing designed for busy pulmonologists, intensivists, fellows, residents, and advanced practice providers. Every week, we review the most important new pulmonary and critical care literature and translate it into practical bedside decisions. Let's begin with what is likely to become one of the most frequently cited respiratory guidelines of the year. If you spend any time in the ICU, you've probably had this conversation more times than you can count. A patient comes in with acute hypoxemic respiratory failure. Someone suggests high-flow nasal cannula. Another person prefers BiPAP. Someone else wonders whether CPAP would be enough. And then, inevitably, someone asks whether we're just delaying the intubation that's going to happen anyway. Despite all the research we've had over the last decade, those discussions still happen because the evidence has been scattered. One trial compares high-flow nasal cannula with conventional oxygen. Another compares helmet non-invasive ventilation with face mask non-invasive ventilation. Another looks only at COPD exacerbations or post-extubation patients. It's been difficult to step back and see the bigger picture. That's why I think this new ATS guideline is worth paying attention to. Published in the American Journal of Respiratory and Critical Care Medicine in June 2026, this isn't new research. It's an attempt to bring together the best available evidence and answer the question we actually face at the bedside. Which form of non-invasive respiratory support should I use? And when? The panel looked at 4 situations we deal with almost every day: acute hypoxemic respiratory failure, acute hypercapnic respiratory failure, pre-oxygenation before intubation, and support after extubation. They used the GRADE methodology and based their recommendations on multiple systematic reviews and network meta-analyses rather than relying on individual trials. Let's start with hypoxemic respiratory failure, because that's probably where most of us were looking first. The panel reviewed 39 randomized trials involving nearly 3,000 patients. That's a substantial body of evidence. What surprised me wasn't that they recommended high-flow nasal cannula. Most of us already use high-flow nasal cannula early for these patients. What surprised me was the strength of the recommendation. High-flow nasal cannula received a strong recommendation over conventional oxygen therapy. Now, before we automatically think strong recommendation equals mortality benefit, that's not really what happened here. The biggest and most consistent advantage was a lower likelihood of intubation. Mortality signals were less consistent. That's an important nuance because avoiding intubation is valuable in its own right, but it doesn't necessarily mean we're changing long-term survival. The guideline also supports both non-invasive ventilation and CPAP for de novo hypoxemic respiratory failure, but only with conditional recommendations. That doesn't mean these therapies don't work. It means the certainty of evidence isn't as strong, and there isn't convincing evidence that they should routinely replace high-flow nasal cannula as the initial strategy. Moving to hypercapnic respiratory failure, there really aren't many surprises. Non-invasive ventilation remains the standard. The panel gave it a strong recommendation because the evidence consistently shows reductions in mortality and the need for invasive mechanical ventilation. That's reassuring because it's exactly how most of us already practice. High-flow nasal cannula does appear in this section, but I don't think anyone should interpret this as high-flow nasal cannula replacing BiPAP. The recommendation is much narrower. If the patient has relatively mild acidemia, around a pH above 7.25, and you're in an environment where you can watch them closely and escalate quickly if needed, high-flow nasal cannula is considered a reasonable alternative. That's very different from saying high-flow nasal cannula should become the default therapy for acute hypercapnic respiratory failure. The sections on intubation and extubation are equally practical. For pre-oxygenation, the guideline recommends either high-flow nasal cannula or non-invasive ventilation instead of conventional oxygen because both strategies reduce peri-intubation hypoxemia. That's probably something many ICUs have already incorporated into practice. After extubation, the recommendations become more individualized. If the patient is relatively low risk, high-flow nasal cannula is a good option. But if you're dealing with someone who's older, obese, hypercapnic, has been ventilated for a prolonged period, or simply looks like they're at high risk of failing extubation, the guideline leans toward non-invasive ventilation instead. One thing I appreciated is that the authors don't pretend these recommendations answer every question. There are still areas where the evidence just isn't good enough to declare a winner. In several places, they essentially say, "Here are the data. Use your clinical judgment." Honestly, I find that refreshing. Too many guidelines try to create certainty where none exists. Of course, there are limitations. Much of the evidence is moderate or low certainty. Many studies came from centers with considerable expertise in non-invasive respiratory support, and intubation decisions are difficult to study objectively because clinicians know which treatment the patient is receiving. So what's my biggest takeaway? It isn't that high-flow nasal cannula has suddenly beaten every other device. It's that this guideline shifts the conversation away from which machine is best and toward which patient is sitting in front of me. That's a much more useful way to think about non-invasive respiratory support. In practice, this means high-flow nasal cannula should be your default starting point for most patients with de novo hypoxemic respiratory failure. Non-invasive ventilation remains the cornerstone for acute hypercapnic respiratory failure, and after extubation, the choice of support should depend on the patient's risk profile rather than a one-size-fits-all protocol. I think most of us have been taught to be a little nervous about hyperoxia after cardiac arrest. The reasoning is pretty intuitive. The brain has already been through a period of ischemia. Then we restore circulation, flood the tissues with oxygen, generate reactive oxygen species, and potentially make reperfusion injury even worse. It's one of those ideas that makes so much physiological sense that it almost feels like it has to be true. So when I saw the logical trial published in the New England Journal of Medicine, I was genuinely interested to see whether the clinical data would finally match the physiology. This wasn't a small study. The investigators enrolled 1,840 comatose adults after cardiac arrest from 53 ICUs across Australia, New Zealand, and Ireland. These were patients who had achieved return of spontaneous circulation, but remained unresponsive and mechanically ventilated in the ICU. One thing I liked immediately is that they weren't comparing two unrealistic oxygen strategies. Nobody was trying to make patients hypoxemic. Both groups accepted oxygen saturations down to about 90%. The real question was what to do once patients were comfortably oxygenated. In the conservative group, clinicians actively reduced oxygen whenever the saturation climbed above 95%, even decreasing the FiO2 to room air if possible. In the liberal group, there wasn't an upper saturation target, and ventilated patients always received at least 30% oxygen. Honestly, that's a comparison many of us can relate to because I've seen both approaches used in different ICUs. So what happened? The short answer is not much. The primary outcome was survival, with a favorable neurological recovery at 180 days. The conservative oxygen group achieved that outcome in 38.2% of patients. The liberal oxygen group, 39.7%. The relative risk was 0.97, with a 95% confidence interval from 0.87 to 1.09. In other words, there was no meaningful difference between the two strategies. I'll admit, that surprised me a little. Not because I was convinced conservative oxygen was better, but because this is one of those areas where the physiology is so persuasive that you almost expect the clinical trial to show at least a modest benefit. Instead, it really didn't. And I think that's the most important lesson from this paper. Sometimes we fall into the trap of thinking that if a mechanism makes sense, changing that mechanism must improve outcomes. Critical care has taught us over and over that biology is rarely that simple. The trial doesn't tell us hyperoxia is harmless. It tells us that carefully avoiding modest hyperoxia in the ICU didn't translate into better long-term neurological recovery. Those are two very different conclusions. Another point worth mentioning is where this study took place. Everything happened in the ICU. Continuous pulse oximetry, frequent arterial blood gases, experienced critical care teams adjusting oxygen minute by minute. That's very different from trying to run a restrictive oxygen strategy in the ambulance or emergency department, where oxygenation is much less predictable. So I don't think we should overgeneralize these findings. There are still situations where excessive oxygen exposure may matter. There are probably patients we should still avoid leaving on an FiO2 of 100% for hours, simply because nobody turned the dial down. This study wasn't asking that question. It was asking whether a deliberately conservative oxygen protocol improves neurological recovery. And based on these data, the answer appears to be no. Like every trial, there are limitations. The treating teams obviously knew which strategy patients were receiving, although neurological outcome assessment was blinded. And the results apply specifically to comatose, mechanically ventilated adults managed in experienced ICUs. That's the population we should feel comfortable applying these findings to. So what's changing in my own practice after reading this? Honestly, probably not very much. I'm still going to avoid hypoxemia. I'm still going to avoid leaving patients unnecessarily hyperoxic. But I'm also going to stop expecting that fine-tuning the oxygen saturation by a few percentage points is going to be the intervention that determines whether a patient wakes up neurologically intact. There are simply much bigger drivers of outcome after cardiac arrest. In practice, this means oxygen remains a therapy to optimize, not a therapy to chase. Use enough to maintain adequate tissue oxygenation, avoid prolonged unnecessary hyperoxia, and focus the rest of your energy on the aspects of post-cardiac arrest care that have a much larger impact on recovery. Let's finish this week with something a little different. Not a randomized trial, not a new guideline, just an excellent review that reminded me why physiology still matters. The paper, published in Intensive Care Medicine, focuses on hypercalcemia in critically ill patients. At first glance, it doesn't sound like the kind of article you'd immediately click on. Hypercalcemia isn't exactly an everyday ICU admission. But here's the thing. When it does happen, it's usually telling you something important. And if you focus only on lowering the calcium, you're probably treating the laboratory value instead of the patient. One point the authors make early, and it's something I think many of us forget, is that not every elevated total calcium is real hypercalcemia. Think about your ICU patients. They're hypoalbuminemic. They're acidotic. Many are on renal replacement therapy. Some have received massive transfusions. Those are exactly the situations where total calcium becomes a poor reflection of what's actually happening physiologically. The review argues that whenever you're trying to diagnose clinically important hypercalcemia in a critically ill patient, ionized calcium is the value you should trust. Correction formulas based on albumin can be misleading and may even overestimate the true calcium level. That may sound like a small point. I don't think it is, because once you convince yourself a patient has severe hypercalcemia, you've already started down a diagnostic pathway that may not even be necessary. Another part of the paper that I found helpful is how it simplifies the differential diagnosis. Rather than memorizing a long list of causes, the authors suggest starting with a single question. What's the PTH? That's it. If the parathyroid hormone is elevated or even inappropriately normal, you start thinking about primary or tertiary hyperparathyroidism. If it's suppressed, you've entered a completely different world. Now you're looking for malignancy, vitamin D-mediated disease, granulomatous disorders, medications, immobilization, or multiple myeloma. I've always liked diagnostic approaches that reduce cognitive load. When you're admitting 3 patients overnight, you don't want to remember 20 different causes of hypercalcemia. You want one question that immediately separates the differential into 2 very different pathways. And in this case, PTH does exactly that. One misconception I think many trainees have is assuming hypercalcemia in the ICU is usually due to dehydration or excessive calcium supplementation. Those certainly happen, but in critically ill patients with severe hypercalcemia, the review reminds us that malignancy is by far the leading cause. In fact, roughly 2/3 of ICU cases are cancer-related, with multiple myeloma, lung cancer, and renal cell carcinoma among the most common culprits. That changes how I think about these patients. Instead of asking, how do I lower the calcium, I start asking, why is this patient hypercalcemic in the first place? Those are very different questions. The physiology is also worth revisiting because it's easy to forget how many organ systems calcium affects. When ionized calcium rises rapidly, neurons become less excitable. Patients become lethargic. They become confused. Reflexes diminish. Cardiac conduction changes. Renal concentrating ability falls apart, leading to profound polyuria and worsening volume depletion. And then the dehydration itself further increases calcium levels. It's a vicious cycle that feeds on itself. One thing I hadn't fully appreciated before reading this review is how often critical illness itself disrupts calcium regulation. Immobilization, acute kidney injury, vitamin D abnormalities, parenteral nutrition, continuous renal replacement therapy, massive transfusion. The ICU creates its own endocrine environment, and calcium homeostasis becomes much more complicated than what we learned in medical school. So where does treatment fit into all of this? Interestingly, the paper spends much more time discussing why hypercalcemia develops than listing medications. I actually think that's the right emphasis, because if you don't identify the underlying mechanism, lowering the calcium today doesn't stop it from coming right back tomorrow. Whether the patient ultimately needs aggressive intravenous fluids, calcitonin, bisphosphonates, denosumab, dialysis, or treatment of the underlying malignancy depends entirely on why the calcium is elevated in the first place. That's the teaching point. Not every hypercalcemia patient needs the same treatment, because not every hypercalcemia patient has the same disease. Like any review article, this isn't generating new evidence. It's synthesizing what we already know. But I think it succeeds because it gives you a practical framework instead of an exhaustive textbook chapter. And honestly, that's what I want from educational reviews. Something I'll actually remember on call. So what's the takeaway I'm hoping sticks? When you see an elevated calcium in the ICU, don't ask, how high is the number? Ask, is the ionized calcium actually elevated? Then ask, what's the PTH? Everything else follows from those 2 questions. In practice, this means resist the urge to treat hypercalcemia as an isolated laboratory abnormality. Confirm the diagnosis with ionized calcium, let the PTH guide your differential, and remember that in critically ill patients, the calcium level is often the clue, not the disease itself. Three very different papers, but they all share a common theme. Good critical care isn't about chasing numbers or choosing the newest device. It's about understanding the physiology, knowing what the evidence actually shows, and applying it to the patient in front of you. This week, the ATS guideline helped clarify how we should think about non-invasive respiratory support. The logical trial reminded us that a sound physiological hypothesis doesn't always translate into better outcomes. and the Hypercalcemia review reinforced that understanding the mechanism is often more valuable than reacting to the laboratory result. I'd love to hear your thoughts. Has the new ATS guideline changed your approach? Do you manage oxygen differently after cardiac arrest? Let me know in the comments. If you found this discussion useful, subscribe for next week's review of the latest pulmonary and critical care literature. Thanks for listening, and I'll see you next week.